All righty. Thank you for recording. All right. So again, welcome to Public Benefits Are Key. Today we're discussing Medicare, Medicaid, and Spenddown. This event is part of our larger Public Benefits Are Key series, where we work with our community experts to share practical information on public benefits that allow our King County homeless service providers to help their clients and community members more easily gain resources that they need. This is also a space for collaboration, to share best practices, to get to know each other, so that we can provide assistance and feel a sense of community. My name is Tim, and I use he and pronouns. And I am here with a couple other members of our organization, the Seattle King County Coalition on Homelessness. We're also joined today by Hannah Rosenberger from Solid Ground. To give a little bit of background on the Seattle King County Coalition on Homelessness, I will say that we are a nonprofit organization. We're a 501c3. We're also a member-based coalition. So we want to be able to understand what service providers and community members are experiencing, so that we can all advocate together to provide necessary resources to our neighbors experiencing homelessness. We are interested in hearing from you so that we can escalate systems level feedback. We do a lot of advocacy at the city, the county, and lately even the state level, so that we can improve system gaps, as well as work to solve systemic causes of homelessness. We have so I want to remind you, anybody that has feedback on the topics in this conversation, questions for myself or Hannah Rosenberger from Solid Ground, please post them in the chat. If you have any questions about the coalition or this event series, you can email me directly at tim@homelessinfo.org. I'm posting that in the chat right now. We'd also love to hear from folks to learn about what is working well in their sector or their workplace, as well as what could be improved upon. How can we advocate together? Please take our event survey so that we can hear from you. Let me post that link in the chat as well. Once you have completed our event today, please feel free to hop in there and give us a little bit of event feedback so that we can improve. Now, a couple things that I will let you know before I pass off to our partner Hannah. We have a lot of activity going on in the coalition right now. We have a general membership meeting tomorrow, where we're going to discuss some important community updates, including changes to the public charge rule, which may affect our undocumented and non-citizen neighbors. The 988 mental health crisis line and other mental health hotline and warm line resources, as well as an update on city and county budgets. I'm going to post that right now. That is a link to register for that meeting if you have not already. We also are expecting a legislative preview for the 2023 legislative session for the state in December. I do not have that link pulled up for some reason, but we will email you shortly with a link to register for our December session. We'll have community partners as well as legislators. So if you're curious about ongoing advocacy updates and just wanting to know about future funding opportunities for the sector, please join us. That will be on December 15th, I believe. And our November meeting will be tomorrow, the 17th. And with that, I would like to pass it over to our community partner, Hannah Rosenberger, benefits attorney at Solid Ground and partner for a lot of our Public Benefits Are Key event series. She's been very helpful explaining topics such as age blind and disabled benefits, housing and essential needs benefits, TANF, and Work First. And now she's here to chat about Medicare, Medicaid, and Spenddown. Take it away, Hannah.
Thanks, Tim. I hope I can keep up the enthusiasm. You did a great job centering us and the meeting. I'm going to share my screen. Just one moment. You know, Tim, do I have access to share my screen? I think usually there's a little button.
Yeah, sorry about that. Let me make
no
you a
problem.
You should be able to now.
Oh, share screen, yes.
Perfect.
Everyone, share. And I'm going to pull up my PowerPoint. I can see you, Tim. Can you see the PowerPoint?
I can see the PowerPoint.
Okay,
yes.
Perfect. So then I'll minimize this. So hi, everyone. Thank you so much for being here today. I may have seen or met some of you before in our previous training, so happy to be here again today. As Tim said, I'm going to be giving a review, an overview of Medicaid and Medicare, and then we'll also be talking about the Spenddown program. My name is Hannah Rosenberger. I use she, her pronouns, and I am a public benefits attorney with the Benefits Legal Assistance Program. We are part of Solid Ground, and we serve clients who are at 200% and below the federal poverty level in the King County area who are dealing with issues with public benefits. So before we begin, I always want to make sure that I name and acknowledge the fact that public benefits, including our medical programs and the policies that develop them, are steeped in systemic racism and can be a form of oppression themselves. So that's a big topic, and we won't be discussing more about that today, but I at least wanted to include a couple links for some additional information. And then also just a reminder that we want to be aware of the impact of using stereotypes when speaking about recipients of public benefits. And again, I included a couple more articles or some additional reading. And before we really get started, I also wanted to let everybody know that because you are participating in today's training, you have access to our Ask a Lawyer program. So what this is if you as a individual or a case manager, if you have a question, or maybe you're working with a client who has a question about the application process or eligibility for one of the medical programs we're going to talk about today, or maybe they were denied a medical service and you're not sure what to do next, you can email questions or real life scenarios to this email address, benefitslegalhelp@solid-ground.org. And if you put Ask a Lawyer in the subject line, one of our public benefits attorney members will respond. We'll either respond over email or set up a phone call. We could do a consultation. Just as an example, we recently were connected with a client and a case manager who the client was about to transition onto Medicare and wasn't sure what that meant for her Medicaid. So we did a consult with the client and the case manager, and then ultimately helped that client apply for one of the programs, Medicaid programs that we're going to talk about today. So just an example, you will see this email again at the end of the PowerPoint. And I'll probably say, oh, that's a great question for Ask a Lawyer throughout the presentation. So just keep this email address in mind. So this is a agenda of what we're going to talk about today. We'll talk about a few of the Medicaid programs we have here in Washington State. We'll talk about the Spenddown program. I'll give a brief overview of Medicare and then discuss the Medicare Savings Program. And then I'll talk about some benefit pitfalls or common issues that we see and how to avoid them. We'll talk about appeal rights, and then lastly, how to refer a case to our public benefit attorneys at Solid Ground. And this is another, this is a helpful definition slide. So sometimes I will use acronyms and I'm not catching myself. So I just wanted to make sure we're all speaking the same language and using the same terms. So the Healthcare Authority, or HCA, that's the state agency that administers most of the Medicaid Apple Health programs. We'll also talk about Department of Social and Health Services, or DSHS, another state agency that administers some of the other Medicaid programs. We will also be talking a lot about income and resources. So I wanted to make sure we define that. Earned income is money from wages or employment. Unearned income is money from other sources like unemployment or Social Security. Maybe somebody's getting a pension, that would be considered unearned income. And when I say resources, or sometimes the term asset is used, what that means is things like cash, savings or checking account, stocks, bonds, mutual funds, cars, property, all those would count as resources. Oh, and I should have mentioned, I can't actually see the chat. So as Tim mentioned, he's going to be monitoring that. And I have several breaks throughout the presentation where we will stop and answer questions or have more conversation. All right, so let's dive into Medicaid in Washington State. You may be familiar with it as that we call it Apple Health. Every state calls it something different, usually, a fruit or a tree. So of course we're Washington, so it's Apple Health. So Washington Apple Health, it's the name for kind of the umbrella term for all the state provided health insurance in Washington. And it includes two of the Medicaid programs that we're going to talk about today. The first one is Magi Medicaid, or you may have heard of it called Adult, Children, and Family Medicaid. That stands for Modified Adjusted Gross Income. So that is based on gross income based on what you're reporting on your taxes. We also have Classic Medicaid, also known as long-term care or age blind and disabled. And this is for people who are age blind and disabled, as the name suggests. There are other Medicaid programs like CHIP, which is healthcare for children, specific health coverage for pregnant individuals. So we won't be going into those programs today, but I just want to flag that they exist, and there's more Medicaid programs than we'll be diving into today. And I just realized maybe this is blocking people's view. So let's start with the basics for Magi, or Adult, Children, Family Medical. So this is Washington's main Medicaid program. This provides health insurance coverage for low-income residents in Washington. And under the Affordable Care Act, adults or families that were not eligible for that classic Medicaid that we're going to talk about because maybe they didn't have minor children or they didn't have a disability, well, under the Affordable Care Act, they can now get Medicaid through Washington Health coverage. Sorry about that. So who exactly can get coverage under this Apple Health program? And here's my bullet point list, age 19 to 64. So if you're below 19 or over 65, there's other programs that you may be eligible for. There are citizenship and immigration requirements. The individual does have to be a resident of Washington State and not already on Medicare. The individual can be a parent or a caretaker of children and be eligible for this program. If a family is using or if an individual is using family planning services program, they are eligible. And the household income is at or below 138% of the federal poverty level. And I have a slide on the next page that will give you some actual numbers. And just to note, children and pregnant persons, they can qualify at higher income levels. So if you're not sure if you or your client is income eligible, I did include a link there. It's kind of a long link, but it gives an overview of eligibility. Or if it's still not clear and you're not sure, you can email us at Ask a Lawyer and we can provide some answers. So these are the income limits for the Apple Health Magi Adult Families Program. So you could see there's different categories. new adult pregnant persons. There's also Apple Health for Kids with or without premiums. And then you can see the federal poverty limit for 1 to 3 persons household. So this is how I mentioned on the previous slide that children and pregnant persons, they could actually have a higher income than just 138% of the poverty limit. And then you could see what those numbers are there. And we will be sending out a copy of the slides. So if I'm rushing through things, just know you will be able to have this as a reference. So what types of income are counted? I mentioned that there are income limits. So what exactly matters? What's counted? And here is kind of a laundry list of different types of income. So things like wages, dividends, if you're getting unemployment benefits, you have a pension, maybe somebody's getting spousal support or Social Security disability benefits. And this is a mixture of earned and unearned income. So if you have a question specifically about, a type of income here, we can definitely talk about that or put that in the chat. And what types of income are not counted? Because not every dollar that a person gets every month is going to be counted as to whether they're eligible or not. Things like workers' compensation, veterans benefits, child support, certain scholarships, certain Native American tribal income, or gifts or inheritance money. So again, if you're not sure if your client's income eligible, you can check out this link here or reach out to us directly. So are there allowable deductions from income? This is, I wanted this to have this piece of information to be on its own slide, because one of the tip I have for advocates is if you're working with a client whose income looks a little higher or maybe is over that threshold from that chart we were looking at, they might still be eligible with some of these deductions. So if somebody is paying out spousal support, or there's interest on student loans, or certain self-employment tax payments that they're making, or deductions, that could be counted as a deduction, so they may be income eligible. So if you're not sure, they can always apply, or again, contact Ask a Lawyer if you're not sure if a certain type of income could be an allowable deduction. And I should say, of course, clients can always contact the healthcare authority or Department of Social and Health Services directly if they have questions about income. So what about resources? What resources count or do not count? Well, the good news is that for the Apple Health, the Magi program that we're talking about now, there is no resource or asset limit. So it's really about what your monthly income is. We are going to talk about other Medicaid programs that do have resource limits, but I just wanted to make sure folks knew that there isn't an asset limit for this program. So how to apply? That's always the big question. Where do you go? Well, Washington or wahealthplanfinder.org, that is the website where people can apply. That is also the website if somebody's going to be purchasing health insurance on the exchange. So there's a button or a link to click for free or low cost Apple Health. And that's what folks who are low income, that's where they're going to want to log in there. You can create a new account or sign into your existing account. Just to note, people are going to need an email address to be able to apply online, because you log in with your email address and you get confirmation sent to your email. There's also a mobile app. It's called Washington Plan Finder. You can apply by phone. I provided the phone number for customer support. You can apply by mail or fax, and these are links to the paper applications. And I really wanted to make sure to highlight the health plan navigators. So there are navigators, health plan navigators, and you can find the people that are in the zip code where you are, your client at, and they will help people go through the application process. They can answer questions about different plans. They're just really a helpful resource, since it can be pretty, if you've never applied for health insurance like this before, they're a really helpful resource. And this is, sorry, but I just need to move something so I can see my notes. What will you need to know when you actually apply? So when you sit down to do the application, what do you need to know in advance? You're going to want to have your household monthly income, or at least an estimate. immigration information, if that applies to you, the date of birth for each household member, and social security numbers for each household member who you're applying for coverage and who does have a social security number. There are certain situations, like for example, with domestic violence survivors, where they may not be required to provide a social security number. And this is a question that we had last time we did this training, so I wanted to make sure we address it. When can I apply, or when can I switch plans? You can apply for coverage anytime throughout the year, and you could also switch plans as often as every month. And I'm going to talk about in a few slides what I mean by plan. You just have to call the healthcare authority, or if you have you've created a portal on Washington Health Plan Finder, you can log in. And the reason why I mention this is right now you may be hearing the term open enrollment, or, oh, open enrollment is closing, or you can only change insurance if you have a life event. And that's true for other health programs. But for this Washington Medicaid program, you can apply any time of the year. You don't have to just do it during open enrollment, and you could switch plans as often as you need to. Well, what changes do you need to report? Let's say something you apply, and then 6 months later, something changes. This is a list of documents that you should report. I'm sorry, not documents, a list of items that if this changes for you or someone in your household, you are going to need to report that. So if there's a change in income by over $150 for 2 months, now that doesn't mean that your coverage is going to change or you're going to automatically lose benefits if your income fluctuates. It just means that you have to report it. And if you are pushed over the income limit, then when you reapply, that might change what you're eligible for. If you move, get married or divorced, if there's a new child in the family or a child leaves the home, if immigration or citizenship status changes, if you get health insurance through your employer, these are things that you need to report. As far as renewal, since I did mention that, your eligibility or certification, you're certified for 12 months. And at the end of the 12 months, you'll get a letter in the mail asking you to renew coverage. You can do that online, over the phone, or in person. And you just have to indicate if there's been a change in income or family or household size at that point to make sure that you renew. And you do have to report any of these changes within 30 days of the change. So it's important to make sure to report those things timely. So I mentioned plans. You can change your plan. There are different plans. And so what I mean by that is in Washington State, we have organizations called managed care organizations. So you may have heard of AmeriGroup, Coordinated Care, Community Health Plan, Molina, and United Healthcare. Those are our 5 managed care organizations. And these are, I'll go to this next slide. Most members who are on Medicaid are going to be enrolled in one of these managed care plans. And this means that they have a set doctor network to choose from. So if somebody's in Molina and they want to know who takes their insurance, they're going to want to they can go to the Molina website and search for a provider. The plans are not available in every area, so there's some in some counties and not in others. And all of these Washington Medicaid plans, they include the same basic benefits, but each plan will offer extras that might convince or entice someone to join one over the other. So just an example, some of the plans may offer a free cell phone or free Boys and Girls Club membership, or maybe some additional testing or rides to medical appointments. And you as a case manager, sometimes I'm asked as an attorney, well, what managed care organization should I choose? And in our program, we don't advise clients which one to choose because it's a very personal decision and there's a lot of information that goes into choosing it. But I do always recommend that people contact a healthcare navigator, which I mentioned earlier, and you can find that information on Health Plan Finder. And that individual can determine the specific medical needs of the client, medical needs of other members in the family, maybe foreseeable medical needs, and then determine what resources or assistance the client could utilize to improve things like wellness or, family coaching or disability advocacy. And then they can choose the right managed care organization that fits the needs. Oh, and I'm going to pause there to see if anybody has any questions about anything that we've discussed so far.
Thanks, Hannah. We do have one question from Felix. Felix says there was a COVID-related state of emergency that extended people's Magi Medicare coverage, but I heard it ended on October 31st. Does anyone know anything about this?
Yes. So we, I'll answer this what I know, and then if there's anyone on the phone, it has been before the public health emergency ends, or before the coverage for Medicaid individuals ends, the state has said they're going to give people 60 days notice. They haven't received information from the federal government saying that it's going to end in January like we thought, so they're not giving that 60 days notice. So that is to say that it's being extended. I don't know if a set date when it's been extended to, but I do know that that's the messaging, that it won't be ending in January, at least the coverage like we thought, because they need to give people notice. It's less than 60 days at that point, so we know it's going to be extended. The news is just coming out yesterday and today, so I'll see if anyone else on the call has maybe some more up-to-date information than I do.
Yeah, Hannah, I think that you're exactly right. The healthcare authority sent out messaging yesterday indicating that we thought that January would be the end of this particular type of extension coverage, and it won't be January. So that's all we know at this point. It won't be January or before. And so we can share, it's something we can definitely share as we learn more information in our regular communications.
Great, thank you, Sarah. Any other?
And that is our only question for now. But if anybody has questions as we continue, please post them in the chat and we'll bring them up at our next Q&A section.
Great. Well, I will jump into the next part of our, the next part of the presentation, which we are going to talk about classic Medicaid programs. Sometimes this is also called age blind and disabled Medicaid programs, not to be confused with the cash assistance age blind and disabled that we spoke about a couple months ago. This is, if you think about when the Affordable Care Act was passed into law and Medicaid was expanded, that's why we call this classic Medicaid, because this is what was in existence before. So this was, specifically for people trying to apply for SSI so that they could get Medicaid coverage. Whereas now, if somebody doesn't have a disability or they're not aged, they have the other option, the Magi that we just talked about. But this is the classic Medicaid programs. So the basics. Who's eligible for this type of Medicaid? Well, 65 years or older, that's the aged part. If you have a disability or are blind, if you have Medicaid with a Spenddown, if you receive SSI, you would be on this type of Medicaid. There's also a Medicaid buy-in option for people who are working that have disabilities. If someone has a Medicare savings program, then they'd be eligible for the Medicaid. And then if someone has or is an adult disabled child, this might be the program that they are going to be on. So not to make it even more confusing, but within classic Medicaid, there are other Medicaid programs. One of them is called Categorically Needy Program, CN. This is one of the classic Medicaid programs. And if there's somebody who is receiving federal cash benefits, so they're getting SSI, they are going to be automatically eligible to receive Categorically Needy Medicaid program. So because it is related to supplemental security income, it has the same income and resources that are tied to the supplemental security income, that benefit. So SSI has a $2,000 resource asset limit. There's also, I'm actually just, oh, it's not the next page, it's in a few pages. I have a chart, but I'll show what those income limit numbers are. So categorically needy SSI related program, as I was mentioning, this is for people who meet SSI, who meet the SSI income and resource requirements, as well as one of the following. I'm realizing now that this slide is a little bit repetitive of what I just said, but I'm going to go through it anyways. 65 years or older, blind or disabled, as defined by the Social Security Administration. And this is also the coverage for most people on ABD. So it is for people who are on SSI, or if they're in the process of applying for SSI and they are on ABD, then they're also going to be on categorically needy. And you could think about the term categorically needy. It's based on like the income, that they're so low income that they're considered part of a category that is by definition needy for this coverage. And disability is defined as unable to engage in any substantial gainful activity because of a physical or mental health impairment. So essentially, somebody who has a disability that is preventing them from being able to work full time. And as promised, this is the chart with the income and resource limits. So 841, that's actually the SSI cash amount for 2022. So you can see that it's the same limit. And then it's a little bit higher if there's a family of two. And then there's this resource limit, $2,000 for an individual or $3,000 for a couple. So how do you apply? How do you get on this type of program? Well, when somebody is approved for SSI or ABD, they may be auto-enrolled. They should be auto-enrolled, but as a precaution, if you have a client that's maybe getting cash and for some reason they don't seem to have medical coverage, they can apply. For SSI, you apply through the Social Security Administration, and then for ABD, and then this program, you apply through DSHS. So I included the WashingtonConnection.org website where all the applications are. You can apply over the phone or in person, and this is a link to the different DSHS offices around the region. So that was a pretty short overview of categorically needy. Or did I say critically needy? Categorically needy, I'm sorry. So I'll pause here for questions to see if there are any questions.
Yeah, we do have a question from Denise. Denise asks, what is the definition of household? What about an adult living? What about an adult child living with a parent?
Yes, great question. So if there is a couple that's married, that's going to be a single household. But if it's two adults living, like you mentioned, an adult child living with the parent, they're going to be their own, each person will be their own household. So when I said, that's actually a great question, Denise. I'll just go back to this slide. Household side is as two. Really, that should say married couple rather than just a household of two. So thanks for pointing that out and asking that question.
Thank you. And Ali asks, what is the difference between Medicare and Medicaid? I'm not sure if you want to answer that now or if you plan to address that coming up.
Yes, great question. We will be talking about, right now we've been talking about Medicaid, and we are going to have a section about Medicare. So I will talk about the differences then, if it's okay to just pause on that question for a few more minutes.
Okay, if that's all right, that is our final question at the moment.
Okay. Just gonna turn the light on in the room. It got dark really quickly all of a sudden. Okay, so now I'm going to talk about what's called the medically needy program. So again, this is another one of those classic Medicaid programs, and this provides coverage for people who are aged, blind, or disabled, institutionalized, hospice individuals, pregnant persons, children, and refugees with income above the categorically needs standards that we just talked about. So I mentioned that that income limit is $841 for a single person. So if somebody is age, blind, or disabled, but their income is more than $841, this might be the program that they're eligible for. And an individual may qualify for the medically needy program with or without a spend down. So who is eligible? As I mentioned, someone who's blind, aged, pregnant, disabled, or a child or a parent of a minor child. They have income that's too high for the regular Medicaid eligibility that we just talked about, and have medical expenses significant enough that when those medical expenses are subtracted from the person's income, it actually brings down their income significantly so that they're under the level that the state determines someone is eligible for the medically needy program. And on the next slide, I'll have what those dollar amounts are. This does have a resource limit. It's typically $2,000 for a single individual. And this program is called, I always think it's helpful to sort of explain why programs are called what they're called, because that helps me remember more than just, remembering the acronyms. But this is called medically needy because it's for people who have such high out-of-pocket medical expenses that after everything is considered and all those expenses are paid for, it really brings down their income significantly so that they don't have enough income to meet their basic needs. So this might be somebody who's on Social Security disability. So the income's a little bit higher than SSI, but they're still low income. So there's not a hard income limit to this program the same way that we have an income limit for categorically needy that we just talked about. But what happens is the more income you have over the income standard, the more you're going to have to spend out of pocket to get this coverage. So that's why instead of monthly income limit, we call it a monthly income standard. And you'll notice it's $841, which is the SSI amount. And that's the minimum amount that the government has determined that everyone should be able to meet their non-medical daily needs with that dollar amount. So I think we all here in the room know that $841 is not enough to meet people's basic needs, especially in such a high cost area like King County. But this number basically matches that SSI cash amount every year. So it does increase every year as there's cost of living increases with Social Security. And there are resource limits here, which you can see to the chart to the right, and it's based on household size. So how does this program actually work? So if you're eligible for the medically needy program, so again, age, blind, or disabled, you can get Medicaid coverage once you incur a certain amount of medical expenses during a specific time. So that's the spend down. Sometimes we call it spend down amount or just spend down. And your excess income, that's the amount of your countable income that exceeds the amount of your income set aside for non-medical expenses. So that's that $841, at least for this year. And the amount of monthly excess income you have, that's what's going to be used to determine your spend down amount. So I have an example of how it actually works so you can see it. Hopefully it becomes a little bit more clear. So I mentioned that there's a specific time period that's involved with this program. We call that a base period. And that's the time period used to calculate your spend down amount. So it's either going to be 3 or 6 months. And DSHs, they calculate your spend down amount by multiplying the number of months in your base period by your excess income. So just for an example, let's say we have a client who has $40 in excess income and they have a 3-month base period. So their spend down amount is going to be $120. And once they have incurred $120 in medical expenses, they can start getting Medicaid coverage, and Medicaid is going to start paying the rest of their bills for the rest of the 3 months because that's their base period. And just in case anyone's anticipating this question, I am going to have a slide about what exactly is a medical expense and what does it mean to have incurred an expense. But before we get there, I just wanted to give another Spenddown example. I'm the kind of person that I have to see something a couple times to be able to catch it. So let's just take our client, Sam. Sam gets $1,200 a month in Social Security disability. We know that Sam will get a $20 deduction for unearned income. And we know this because this is just part of the calculation and the rules for this program. So if you're working with a client and you're not sure what their spend down amount is, that's a great Ask the Lawyer program because we can kind of help do the math. And I will say that if somebody is working and earning ages, the calculation's a little bit different because earned and unearned income is treated differently. But we're going to go with Social Security disability for this example. So Sam's countable income is $1,180. So Sam gets to subtract $841 from that amount to be able to set aside for the non-medical expenses. So her excess income is $339 per month. And let's say Sam has a 3-month base period. So her spend down amount is going to be $1,017. So as soon as Sam gets medical bills that add up to $1,017, she can start getting Medicaid coverage, and then Medicaid will pay the bills for the rest of the 3 months. And you may ask, well, how does anybody know what medical bills and medical expenses she's incurred? Well, as soon as clients get medical bills, they should submit, and they submit copies to DSHS, to the spend down unit, and then that amount gets noted, and then that's how they'll know if they've met their spend down amount. So clients can submit medical bills as they come. They can keep them in a folder until they reach the spend down and then submit everything together. My advice is that clients should make copies of anything that they submit to DSHS to prove their spend down, so that they have their own copies as well, and they're not having to rely on DSHS's record keeping. And also, what do I mean by Medicaid starts paying bills? Well, if somebody is on Social Security disability, they're going to be getting Medicare, which we are going to talk about more. Medicare generally covers 80% of a medical expense, and then the client has to come up with the other 20%. So in Sam's case, let's say she has a couple co-pays that she's having to pay because she only has Medicare and she still has some of her own obligation. So once she's paid enough co-pays or prescription co-pays, or maybe she had a surgery and she had to pay a significant amount, once she's met that $1,017, then that provider is going to be able to bill Medicaid directly, and Medicaid is going to start covering what Medicare isn't covering, that extra 20%. So that's an example of how that coverage actually works. So some tips and things to remember about spend down. Eligibility is 3 or 6 months. Sometimes it's a strategic decision about whether someone should choose 3 or 6 months. If somebody has a 6-month eligibility period, that runs from January to June. So they have to meet their spend down amount by June. And then it resets in July, and they have a whole new period and a new dollar amount that they have to meet. And then again, clients should submit copies of bills to DSHS to go towards the spend down amount. So let me just see if there was anything else on this slide I wanted to make sure we covered. Okay, I'll move on to the next slide. So a really important tip about spend down is, when I said they have to have incurred a medical expense, it doesn't mean that they actually have to have paid that bill. They just have to have the obligation to pay that bill, and then that's considered that they've incurred the expense. So let's say our client Sam, she got a bill for $300, but she hasn't paid it yet. She can still submit a copy of that $300 bill because she now has that legal obligation to pay for it. So she's incurred that expense. Just a note, if you're working with a client maybe who was in a car accident, so insurance is going to be paying for the medical bills. That isn't something that's going to be able, they're not going to be able to count that for their spend down. When a third party is liable for payment, that can't be counted as part of the spend down because the client themselves doesn't have that obligation to pay for it. Another tricky thing that we sometimes see with spend down is for an expense to be allowed towards spend down, that expense or procedure must have been prescribed by a licensed provider. So just an example, I have a client that uses a lot of holistic products, but her provider actually does prescribe, although maybe you wouldn't normally need a prescription for that, she does have a prescription for these like herbs, for example, or teas. And so that is why she's able to use it to apply to her spend down. I'm just checking through my notes, see if there was anything else I wanted to make sure. Yes, so one of the helpful things about spend down is this can be used to help clients get mental health coverage that they maybe wouldn't otherwise be able to pay for or afford themselves with Medicaid. So as I mentioned, somebody doesn't have to actually pay the bill to have it count towards their spend down. So if a client's working with a provider who will allow them to have that outstanding balance, once the client meets their spend down, then Medicaid will step in and that provider can then bill Medicaid for the rest of the care. So, obviously not every provider is going to do that, but, maybe if you're working with a nonprofit medical provider or someone who understands the needs of the community, that might be kind of a creative way for clients to get the care that they need through spend down. So how do you apply for medically needy? Well, this coverage is available through DSHS. That's how you apply. WashingtonConnection.org. Again, as I mentioned, that's where the applications are. You can do it over the phone or in person. And then once you're enrolled, you have to submit proof of the expenses to DSHS. And you could submit copies of those bills in person, you can mail or fax them. There's not a way to electronically upload documents yet, although the state is working on that. But that's the important part because DSHS isn't going to know that somebody's met their spend down unless those medical records or expenses are submitted. So I'll pause there. I know that's a lot of information and I'll just see if there's any other questions. And then our next section is going to be about Medicare as a preview.
Yeah, we do have one question from Felix. They ask, what would be the pros and cons of choosing a 3-month base period versus a 6-month base period?
That is a great question, Felix. I'm gonna go back and I'll just feel like we're a smaller group today, so I can admit this. I usually print out my notes. Today I'm trying something different where I have my notes on another screen, and I actually have an answer, Felix, to the question that I meant to say. So thank you for bringing that back. Okay, so in general, it's generally more convenient to have a longer base period because once you meet your spend down, if you have a high expense at the beginning of the spend down, you meet it early, and then for the next 6 months or however long it took you to meet your spend down, you're getting Medicaid coverage. So it's kind of a longer period of time that you're able to get coverage. But there's some math involved, and it really does depend on the specific client and what their needs are. So for example, let's just use our client Sam again. Let's say Sam has a spend down amount of $90. Oh, I'm sorry, I'm looking at my notes here. And I only have half of my example there. So I'll just wing it. Let's say a client has, for a 3-month period, their spend down would be $90. So maybe they have whatever the math would be, 90 divided by 3, that's their monthly spend down limit. But if they have if it's a 6-month face period, then their spend down might be $180. So if a client is going to have a large expense, like maybe a surgery, and they're going to have it at the beginning of their 6-month face period, then it would make more sense for them to have, I'm sorry, they're going to have it at the beginning of their base period. That would make more sense for them to have a 6-month period, because they're meeting it early on, and then they're going to get coverage for the rest of that 6-month period. Whereas if they had just a 3-month period, they would meet it pretty early on, but then they would only have maybe 2 months or a half a month where they're going to get Medicaid coverage. So it really depends on what expenses the client thinks they're going to have, and if they might easily be able to meet their spend down, or if it's going to take longer to meet the spend down. So those are some of the questions that you might want to think about for the 3 to 6 month base period.
Awesome. Thank you for that. We have 2 more questions. Denise asks, will Medicaid pay for expenses that were part of the spend down calculation if they haven't yet been paid?
Great question. So no, if something has been used to get you to your spend down amount, Medicaid is not going to pay for that. But once you hit your spend down, Medicaid will start paying for that. So the client is either going to have to pay that bill, or work something out with the provider, or hopefully the provider doesn't send that to collections or something like that. But yes, Medicaid only starts paying after the spend down amount.
Okay. Then we have a similar question from Hannah, and I think that past answer shed some light on it, but is it advisable for the individual to incur all those expenses just to have to meet the spend down if they'll still have to pay it all off afterwards?
It's that's a good question. And that's the tricky thing about spend down, is the client is you do have to incur some kind of expenses that you're going to be responsible for to meet the spend down amount. What I will say is, again, why this is called medically needy is this is for people that already have pretty high out-of-pocket medical expenses that their other coverage, their Medicare, for example, is not paying. So I don't know if the situation is necessarily that a client is going out of their way to pay, get these expenses to then meet spend down. It's really more for clients that already have those really high out-of-pocket expenses. So they get a break, basically, that instead of having to pay, all $3,000, maybe they have to pay $1,000, and then the other $2,000 is covered by Medicaid.
And we have a follow-up question from Felix. They ask, so to qualify for spend down, would a person need to pay the full amount of the bill, let's say if it exceeds the spend down on its own?
Yes, great question. So let's use our example, Sam. I think we said she had a $1,000 spend down amount. Let's say she gets a bill for $1,500. Then she's met her spend down amount with just that one bill. And then that second $500 part of the bill, that's going to be able to be billed to Medicaid, and the state is going to pay that. So one bill can actually get someone to their spend down amount, and whatever is over the spend down amount of that bill, they can get covered through Medicaid. So that's just, I think I was speaking in circles a little bit there. So I'll say, yes, if one bill exceeds the spend down amount, the client's still responsible for their portion of that spend down amount, but then the rest of that bill can get paid for through Medicaid.
All right, that was the last question at the moment.
Okay, so let's talk about Medicare. So I know someone earlier asked, well, what's the difference between Medicare and Medicaid? Medicare is a federal health insurance program, and Medicaid is the state health insurance program. So there are other differences, certain things like Medicare has premiums, Medicaid doesn't. But the big difference that you could think of is that Medicare is the federal health insurance program and Medicaid is the state version of health insurance coverage. So who can actually get Medicare? If you're 65 years or older, you have to have worked under the Social Security or retirement system. So that's like paying your Social Security taxes on your paycheck. Certain younger individuals with disabilities may also be able to get Medicare, or if somebody has a disabled parent. People with end-stage renal disease and other kidney failure conditions can get Medicare. There are citizenship and immigration status requirements. And like I mentioned, there are premium costs for Medicaid. So there are 4 different parts of Medicaid coverage. Medicare part, I'm sorry, I think I keep saying Medicaid instead of Medicare, so I apologize. Medicare Part A, we also call that hospital insurance. So that covers things like hospital stays, if someone needs to go to a skilled nursing facility, hospice care, and some types of home health care. Medicare Part B is medical insurance. So that's things like doctor visits, outpatient care, medical supplies, and preventative services. There's also Medicare Part C, which is optional medical coverage. This is also called a Medicare Advantage program. And so that means there's a managed care. A lot of folks in Washington, for example, may have a Humana as their Medicare Advantage provider. And then Part D is prescription drug coverage. So this helps cover the cost of prescription drugs, including things like shots and vaccines. And there are premium costs with Medicare, unlike with Medicaid. So most people don't have a premium for Medicare Part A, and the standard Medicare Part B premium is $170.10. It might be higher depending on your income, and that dollar amount usually changes every year in January. The Part C plans, those premium plans, Medicare Advantage, they vary by plan, the cost. And that's the same thing with Part D monthly premium. Premiums vary by the plan. So I included 2 links that when you get the PowerPoints, you'll be able to access. That brings you to Medicare.gov, and there's an option to compare plans on Medicare.gov. So a really great resource for people with questions about Medicare or who need help applying or having issues with their Medicare is the statewide health insurance benefits advisors, or known as SHEBA. So they provide free, unbiased, and confidential help with Medicare to people of all ages and all backgrounds and all income limits. In Benefits Legal Assistance Program and Solid Ground, we actually help clients with Medicaid issues. So we don't actually advise or provide assistance with Medicare, because that is, it's a whole other animal. So that's why we really just strongly recommend people reach out to SHEBA. They're very well trained and have a lot of great information, and they can help a client assess healthcare coverage. They can help determine what program that they're eligible for, what their premiums are going to be. They can actually even help the client enroll in Medicare. They could talk to Medicare on behalf of the client, make referrals to other programs, and they also collect and report if there's any concerns about Medicaid fraud complaints. They also help with those as well. Here is the phone number for SHEBA and the website. In King County, the SHEBA program actually is out of Solid Ground, which is wonderful. You can still contact the 1-800 number or visit the insurance.wa.gov website to get all the contact information. Or if you're in another county, you'd want to check that out as well. So I mentioned premiums. And oftentimes we get a question, well, can I get help paying for my Medicare premiums? And the answer is yes, if you qualify for a Medicare savings program, which is the next type of Medicaid program that we're going to talk about. So if you're on Medicare, you can qualify for help with those Medicare premiums, but also things like deductibles and cost sharings. So I mentioned earlier when we were talking about spend down that usually Medicare will cover 80% of an expense, and then the client has to pay that other 20%. Well, there is a Medicare savings program that will actually pay that 20% for the client. So there's 4 different programs within the Medicare savings program. I think of them as levels because they're based on income levels. So I just want to reiterate, the Medicare savings program, that's not medical insurance. It's just a program that will help pay for the Medicare premiums, but you're not actually going to get a doctor from the Medicare savings program. It's just it's a financial assistance program. So who is eligible for the Medicare savings program? First of all, the individual has to already be receiving Medicare. They have to be a Washington state resident, 65 years or older, receiving Social Security disability benefits, or certain people with certain disabilities or permanent kidney failure, even if they're under the age of 65, and they meet standard income and resource limit. And I'm going to talk about that resource limit in just a couple of slides because there's some big changes coming there. So I mentioned there are 4 levels or programs within the Medicare savings program. The first one is called the Qualified Medicare Beneficiary, or QMB. This pays for Part A and Part B premiums if somebody did have a Part A premium. This will pay for the deductibles and co-pays. So this is the program that I mentioned that will cover that other 20%. This is the most robust Medicare savings program, excuse me. And we often call people who are on the QMB program dual eligible. So that's kind of a common term. If someone says I'm dual eligible, this is what they're probably talking about. There's another level, the Specified Low Income Medicare Beneficiary. This will pay Part B premiums. Qualified individuals, that will also pay Part B premiums. And there's a 4th level called Qualified Disabled Working Individual, and that will pay for Part A premiums. And that is for individuals who used to be on Medicare. Maybe they used to be on Social Security disability benefits, but they lost that coverage because they went back to work and now they're earning too much. Well, they're still able to get access to this program to help with those out-of-pocket premium expenses. So these are the income limits for the different Medicare savings programs. You can see that QMB is 100% of the federal poverty limit, or 1,133. So it's pretty low income, and that's why it's some of the most comprehensive coverage, because the people that qualify for it are so low income. And then it goes up to 120%, 135, and then that 200% for the qualified workers. And just a note, if somebody is getting the QI-1 for the qualified individual, this person, they cannot get those benefits if they qualify for another type of Medicaid program. So it just means that if somebody would be eligible for one of the other Medicaid programs we talked about, they're not going to be able to get this assistance paying with their premiums. So oftentimes we see clients that, they just don't have any other, they're not eligible for any other program, but at least they get this to help with their premiums. So currently, at least through the end of the year, there are resource limits for the Medicare savings program. It's $8,400 for an individual, or $12,600 for a couple. And it's a little bit different for the qualified disabled workers. But this resource limit is actually going to be eliminated in January 2023. So a lot of legal aid advocates and other community advocates worked really hard to eliminate this resource limit. And this was and will be especially important for people who are living on very fixed income, but are not able to really save any money, because then they would be kicked off this program, which, as you can see, actually does pay for, pays that premiums. It might pay co-insurances. So it's a really important program, and people were not able to access it if they had been able to save a little. So that's going to be eliminated next year. So there will be no more resource requirement. The income limits, that still sticks, but not the resource limits. So I just wanted to flag an issue that we oftentimes see, and you as case managers or individuals may see as well. So there's actually a federal law that prohibits Medicare providers and suppliers from billing people that are in the QMB program for that medical cost sharing. So that 20%, that Medicare cost sharing, or the cost of a supply above what Medicare will pay for it. They actually have no legal obligation, the clients, to pay those deductibles or co-pays for any Medicare covered items and services. But we do often see clients getting wrongfully billed. So if you have a client that is on QMB or says they're dual eligible and they're getting a bill from a provider, that would be a great ask the lawyer question or a referral to our program, because we often have to advocate on behalf of clients. Because what we don't want to have happen is someone that's in QMB get a medical bill that eventually gets sent to collections when really they shouldn't have been billed in the first place. I already mentioned the issues unique to the qualified individual, just that they cannot be enrolled in other government funded programs while they are on this benefit. This is related to the Spenddown. So if anybody does have questions about how DSHS is calculating their client Spenddown or their own Spenddown, or whether they're eligible for the qualified individual level, just feel free to reach out because it can get a little complicated. And how do you apply? Well, it's easy. You can contact the local DSHS office, apply online, or you can also contact the healthcare authority. But when somebody gets on Medicare, if they're low enough income, they're actually enrolled in something called Extra Help that you may have heard. It's a prescription income, a low income subsidy. So when somebody is enrolled in that program, they're actually supposed to be automatically enrolled in their state's Medicare savings program. But we don't always see that happening. So that's why I say, the but or should be automatically enrolled. But if you have a client that seems like they would qualify, but they're not on the Medicare savings program, that's when I would encourage them to just go online or go into the office and apply, because they may not have been automatically enrolled, even if they should have. I will pause there. And just as a preview, the next section is going to talk about common issues and kind of benefit pitfalls, but pause here for questions.
Hannah, I think you're doing a fantastic job of explaining, because there are currently no questions. If anyone does have a question, let's see, I think I should be able to view everyone. Feel free to raise your hand or type something briefly in the chat box. Otherwise, we will keep rolling.
Okay. And I will have all of my contact information. I'll put that in the chat. And people will get the slides. So if you review the slides on your own and you have additional questions, reach out to us at Ask a Lawyer, or you can contact me directly. So what the point of these public benefit or key presentations, or at least one of them, is to try to give practical advice and suggestions for direct service workers when they're working with clients in the different programs that we're talking about. So I'm trying to make it be really practical. And one thing that I've noticed is helpful is if I can give examples of kind of benefit pitfalls or things that go wrong, and then some advice and examples about how to avoid those issues. So one common issue that we often see when we're talking about medical programs is that someone's benefits, they might be denied. So they apply for one of the programs we've discussed and they've been denied, or maybe they've been terminated because there's a change in their income or resources, or they were supposed to report something and they didn't do that, or they didn't know that they were supposed to report. There's also the case where actual services, procedures, or prescriptions can be denied. Excuse me. So the person's still getting their medical coverage, but something specific has been denied. So just, a common example is maybe the client needs a surgery, but the coverage for the surgery is denied because it's not medically necessary. Or there's another option available. Child's braces can sometimes be denied for the same reason. Or a prescription might be denied because the drug is being used for a purpose different than what it was approved by the FDA. Or maybe the doctor that's prescribing the prescription is not considered a specialist, the person who should be describing that specific medication. So for example, a general practitioner may be prescribing like a dermatology medication. Or this is a case I recently worked on with a client. Their coverage for the brand name was denied because the doctor didn't prescribe the generic, or the healthcare authority said, you can just get the generic brand. But my client had an allergic reaction to the brand, to the generic. And so that's why she needed the brand name. So these are just some examples of things that can go wrong with coverage. And all of this is to say that legal services can help with these types of problems. People don't always think of like the denial of a surgery as a legal issue, but clients actually have the right to appeal these decisions. There are also other ways to get coverage. I don't have a slide about this today, but there's something called an exception to the rule. So for example, if a prescription is denied because it's different than the purpose approved by the FDA, we've worked with clients to get exceptions approved so that they actually can get that coverage. So if you're working with a client and there's just some coverage issue, that would be a great ask the lawyer question to just email and see, what can be done about this? What are the client's rights, or what are the other options to get coverage? I recently was working with a client whose power wheelchair was denied because the insurance company didn't think it was medically necessary. So we helped the client appeal, we worked with the doctors, and we were able to get that approved. So just some other examples. So if something does go wrong, you could, of course, contact us and see if we can help, but the client can request a hearing. That's how you appeal decisions with these public benefits, is you request a hearing. They're called administrative hearings, and it's essentially when a judge, someone that's not part of Healthcare Authority or DSHS, looks over the case to see if the department did something wrong. The individuals have a right to be represented by an attorney at these hearings. They can also have an advocate, so a family or a friend can also be there. And to request a hearing, you can contact DSHS at this number here. I also included the number for the Healthcare Authority, the Office of Hearings Administration. Clients can go in person and ask for a hearing. They can do it over the phone. They can do it in writing. There's not a magic word. The client doesn't actually have to say, I am requesting a hearing. They just have to express that they disagree with the decision. And either Healthcare Authority or DSHS, they always have to notify people in writing when they make a decision about, a benefit or a service. And that letter will include the person's hearing rights. It'll include, the right phone number to call, the address, exactly how to go about requesting a hearing. So that's also a good place to look at if you don't remember how to ask for a hearing. There are deadlines to request a hearing. Usually it's 90 days when you request a hearing from the adverse action. So this is if somebody's maybe being terminated or there's a change in their benefits. Individuals can request continued coverage. Like for example, if they get a notice that their Medicaid is being terminated, they can ask to keep getting coverage while the hearing is going through. You do have to ask for that within 10 days on the date of the notice. So it's just really important to, as soon as people get those letters, to try to act on them as quick as possible. And then we're nearing the end of the presentation. I just wanted to include this Ask a Lawyer program slide again. Now that we've gone through the presentation and the training, y'all may have a better idea of what kind of questions you may have or issues. So again, you can email benefitslegalhelp@solid-ground.org. Just put Ask a Lawyer in the subject line, and then we'll know that you're reaching out for this program. And then lastly, I've provided our intake line for our general referrals, our email address, and then these are all of our team members and our contact information, and people are welcome to reach out to us individually as well. So I'm going to go back to this slide and then I'll pause there to see if there's any questions or just any comments or conversation anybody wants to have.
Hi, Hannah. There was one question in the chat. Client who is an immigrant, never worked and has no income. Immigration status, green card, has been here, it says 10 years, but over 5 years. What can that person apply for?
Yes. So in Washington State, we do have medical care services that are for people who, are not a citizen. So I think you mentioned the person has a green card. So usually if you're a permanent resident or a citizen, but there are some time requirements or limits, but we do have medical care services as one of the state programs. As far as Medicare,
If the person has, so there, it says under 65, or, so if it says over 45, yeah. So
okay.
it seems like possibly because the person is a legal permanent resident with a green card and has been here for more than 5 years, they might qualify for Medicaid.
Mm-hmm.
And if they don't qualify for Medicaid, then they might qualify for medical care services.
Mm-hmm. And I did mention, we were talking about classic Medicaid, age, blind, and disabled. So I'm not sure if the scenario included anything about,
No.
But if that's something, maybe the reason why the client hasn't been able to work is because they have maybe a disabling condition that's preventing them from being able to work, that might also be a path that they could get Medicaid.
And so another question, what are the options for folks who do not have legal status?
Unfortunately, there aren't as many for folks that do. There are, maybe you can jump in about I think it's called the Alien Medical, I don't remember the name, it's an emergency care services.
Yeah, Alien Emergency Medical Services.
Yes, that's one that I'm thinking of. Yeah.
Very, very limited. You have to have certain, essentially, certain types of conditions that will ultimately, lead to someone's death. I mean, it's like end stage cancers, end stage things. So it's an option for some people, but you really have to be in a, in a dire medical situation. My understanding, and this isn't available right now, but I do know that there is advocacy happening at the state level to create a medical program for individuals without legal status. I don't know a lot about it, but I know it's something that the Washington Immigrant Solidarity Network is working on, and Northwest Health Law advocates are working on, and I think they both have information on their websites about state advocacy. I also think that I think something was passed in the last legislative session that allows individuals without immigration status to purchase healthcare through the exchange. I know that that's not a great option for many of the clients that you all are probably working with, but but it wasn't an option before.
And I will say that children, regardless of their status, should be eligible for coverage. So that's not adults, that's children, but that's something to keep in mind if maybe you're working with a family that has minor children.
And I don't see any other questions in the chat, but we can definitely open it up if anybody
Yeah.
wants to unmute and ask questions.
I'll stop sharing so we can just, stop share. Yeah, I'm happy to answer more questions, or if people have just thoughts or things that would be helpful to learn about or cover in future trainings.
And I
I
think
have
we
a
can
quick-
also drop the survey into the chat again.
Absolutely.
We'd love to hear your feedback.
While I'm grabbing that survey link, I have a quick question for Hannah. So considering Spenddown is a formula to create a threshold after which Medicaid can cover insurance for a person with high medical need. Can you expand a little bit on what you meant by a person has to incur a certain amount but not yet pay? Maybe is that like the
Yes.
crucial word?
Yes, yeah. And I think this is why there may be people out there that could have, met their spend down limit, but they hadn't paid the bill. So they didn't know that could help them. So the individual just has to, so we say incur a medical expense. So that means they have a legal obligation to pay for that expense. So when somebody gets a bill from their doctor, they have agreed that usually when you go to the doctor, you fill a couple forms saying, oh, if insurance doesn't cover X, Y, and Z, I agree that I'll pay the rest. That's usually part of, your intake paperwork. So when the client gets a bill, they have a legal obligation to pay that. And that's all they have to show to have that dollar amount be applied towards their spend down. Now, I think might have been Felix or someone else on the call did point out that once they meet their spend down amount, Medicaid isn't going to go back and pay that unpaid medical bill if that's what is needed to meet the spend down. So the client is still going to have to pay something. But kind of the idea of spend down is that there's a cap on what you have to pay. And once you've met that, you get that coverage. So I actually was working with a client recently this was like maybe 6 months ago, and they had met their spend down by everything that I can tell, but they just had these bills and they had gone into collections, which is why I mentioned that. And they hadn't been able to pay the bills, but they didn't know that could count to show that they had met their spend down. And I don't know if I went into detail about the spend down, but you have your certification period. So you have to meet your spend down within the certification period. And by the time I found these, or they found me, it had been maybe a year or two. So it was outside of the range when we could have tried to use those those bills to apply to their spend down. So it was just a good learning moment for the client. So that's why I really wanted to make it clear that even if client has a medical bill, even if they haven't paid for it yet, they can use that to meet that spend down limit or spend down amount.
Thank you so much. I appreciate that. That will be articulated in the blog coming early next week. Keep an eye out for that.
It can also be strategically used if someone who maybe doesn't regularly have high medical expenses, but they know they're going to have a one-time really high cost of something. A common scenario that I used to see was somebody needing like a dental surgery or medically needy getting dentures or something like that. And so I would do a lot of planning with clients on how long they thought it would take to meet the spend down, and then when they could get the surgery or the procedure or whatever it was scheduled. And we would kind of, you know, manipulate all of the appointments and bills and all of those things to happen in a certain period of time to get the really large expense. You know, somebody has like a surgery coming up that they know is going to be like 12 or $15,000, and just timing everything to fall into a base period. It's kind of like, I always think of it as an insurance deductible, similar to your insurance deductible.
That makes sense.
I really encourage folks to fill out the survey, give feedback. If there's something that they wish we had covered more, or something that, I mean, just anything in the realm of, my specialty is public benefit. So if there's anything related to that, but I'm sure the folks at the coalition, if there's just any other type of training, sure they'd like to hear that too. Yeah, very open to feedback. And I'll put my information in the chat now, so folks can reach out to me directly if there's any other questions.
Thank you, Hannah. We're so happy that you were here to join us today. If there's other questions, we hopefully will see you at future trainings. And Tim, if you have anything else to close us out.
Yeah, just I think a quick thanks to Hannah again. Join us for future public benefits or key trainings to see Hannah and some of our other partners as well. We're going to be talking about some new topics in 2023, including long-term care, SSI and SSDI navigation, and the Working Families Tax Credit, in addition to those classic trainings like ABD, TANF, Medicare, Medicaid, and Spenddown. I do want to share also, just reminding folks that we do have a meeting a general membership meeting talking about some program updates, some budget advocacy updates. This could be really helpful for anybody who may have undocumented or non-citizen clients to learn about the change to the public charge rule. It could be helpful for folks curious about 988 and other mental or behavioral health hotlines or warm lines. Let me just park that registration link in the chat again. And if anybody has questions about the coalition, if you want to give general feedback about public benefits or key or any of our other activities, you can feel free to email me directly at tim@homelessinfo.org. And unless anyone else has questions or comments, I'd like to thank everyone for their time, and yeah, we'll see you at our next meeting. Take care, everybody.
Hello.